Hello and welcome back to the Empowered Podcast, Dr. Paul Goldwater. And I'm really looking forward to our discussion today on your latest paper, which you sent me a link to, which is on twins and SIDS. And I'm just going to briefly pop this paper up on the screen so that people can see it. I will, of course, have it linked in the show notes. So the title of this paper is Insights from Twin Sudden Infant Death Syndrome Studies Could Reveal an Idiopathogenetic Pathway to Sudden Infant Death Through Immunopathology. That's a bit of a mouthful. So we are going to go through this paper in some degree of detail. Could we start with the question of why study twins? What is so interesting about the study of twins? I mean, there were some rather nasty Nazi doctors who were pretty interested in studying twins back in the day, which kind of threw the whole field of twin study into disrepute. But what is the genuine medical interest in studying twins?
Well, there's the coincidental finding that SIDS have a higher incidence of SIDS. Twins have a higher incidence of SIDS, and they also are much more susceptible to infection, and they have a much higher mortality rate from infection-related problems. The risk factors for sudden infant death syndrome it contains a very long list of infection-related factors, and you could show them on from that paper on page 3. And we go through, there are genetic factors, and of course that genetic factors play a role in SIDS. There are genes that are involved in the immune response that seem to be very important in sudden infant death. And there are other issues, there are prenatal issues, and a very long list of those, and postnatal, including a whole range of things. I can go through the extrinsic factors, the demographic factors, low socioeconomic status, high birth order, previous birth.
Explain high birth order for my audience.
Yeah, that seems to be related to the fact that there are other children in the household who will bring infections home.
So a high birth order means that this child might be the third, fourth, fifth in the family.
Right. That's right.
They have old siblings who are maybe attending daycare or whatnot, at going to school, getting exposed to germ soup, basically.
Yeah, that's right. There are prenatal risks, inadequate antenatal care, maternal smoking, nicotine exposure. Smoke exposure increases the severity and mortality of infectious diseases. There's maternal drug use, low socioeconomic status.
Poverty, basically, and poverty, I imagine, would relate to receiving inadequate prenatal care as well. I'm also wondering, is there a higher risk of SIDS in children born in rural and remote areas where they have less access, and say in Aboriginal communities where they have less access to prenatal and postnatal care?
There's quite strong evidence that there is a higher risk in rural areas, yes.
Yep. And there's also, living now in a rural area myself, I can tell you that smoking rates are off the charts. The number of people that I see smoking here just wildly exceeds the smoking rates that I saw when living in Sydney and on the Gold Coast.
Yeah. So when you put the two together, a higher rate of SIDS in twins and a higher mortality rate from infectious diseases, then you've got to ask, what's going on? And how I've analysed it is that the twins are born prematurely. They will often miss the transplacental antibody protection given from the mother because of their prematurity, or they'll get a lower dose. And in fact, if they're sharing that antibody, they're going to receive a lower dose as well.
Oh, that's super interesting. We discussed this briefly in our joint interview with Ted Steele, but could I just have you review that briefly? So for a singleton birth, a non-twin, in other words, the gestational age is 40 weeks. Yeah. What is it for twins?
It's 37 weeks. It's the full term age.
And the transplacental antibodies, so this is antibodies that are passed from the bloodstream of the mother through the placenta to the babies. And again, we touched on this when talking with in the interview with Ted. But so the transplacental antibody transfer, at what week of gestation does that begin, if that is known? And what's
it? About 28 weeks it starts, but and it increases thereafter. Yes. So for any prem, it's not going to get the full dose, and if they have to share that dose with their partner twin, they're going to get a much lesser amount.
They're getting half the dose.
Yeah.
Got it. Okay, interesting. And so the conventional thinking around the increased risk of SIDS in twins has revolved around the fact that twins are basically born premature, and that has been assumed to be the sole or major reason why twins have this greater susceptibility both to infection and also to SIDS.
Yeah.
But you think there's something more to it?
Yeah, well, you have to look at the underlying possibilities that go with prematurity, and there's one of them, the lesser amount or sometimes totally missing amount of maternal antibody. And of course, breastfeeding is going to be an issue, or lack of it, because managing breastfeeding for twins is quite a deal, and many twins will miss breastfeeding and the advantages of protection from colostrum and breast milk. So you've got a setup of now a much more vulnerable baby human being.
Oh, there's one other factor, and this relates also to something else that you discussed in the paper, which is the influence of the gut microbiome on the immune system. And that is the fact that the third most abundant constituent of breast milk is oligosaccharides, which is not a food for the baby because the baby can't digest it. It's a food for gut microbiome, specifically the bifidobacteria. So if the babies are, if twins are less likely to be breastfed again, or they're receiving some breast milk, but they're being chopped up with formula because, as you say, it is a difficult feat to breastfeed a singleton, let alone twins, then these babies are going to have a less optimal microbiome for the development of their immune system. Yeah. So now we're stacking up risk.
Exactly. Yeah. Yes. Yeah. So there you have it. It's all. It all comes down to susceptibility to infection, in my opinion.
And so
yeah.
let's,
So when
go
we
ahead.
move on to immunisation,
Yep.
I regard immunisation as pseudo-infection.
Say more about that, because so parents are often told by the doctor, this vaccine is kind of like a mini dose of the measles or the diphtheria or whatever it is. And so your kid might get a few symptoms, like as if they got sick, but it's going to be less severe. That's obviously a simplistic explanation directed as parents. Do you agree with that? Do you think there's more to it than that?
The basics are correct, yes. If you give an attenuated virus, it's been attenuated so it doesn't cause fatal disease, but it will cause mild disease. And it's designed to stimulate an appropriate immune response and set up immune memory so that the child, whenever it gets re-exposed to that particular agent, will be protected. So that's the essence of why we immunize.
However, go on.
However, there can be problems, usually in a very tiny minority of vaccinees who may not respond in the right way and may have an abnormal immunological response, and that could be catastrophic. But it is rare and relates mainly to the general health of the child and its genetic background and its level of immunity and how well innate immunity works. And that's all controlled genetically, and how the adaptive immune system works or fails. And
gotcha. Okay. So in the paper, you discuss a number of reports to VAERS, the Vaccine Adverse Events Reporting System, of babies, twin babies who received a vaccine and subsequently died, and the death was attributed to SIDS. What are the key elements of these reports?
Well, unfortunately, the data is relatively weak because these systems are passive in terms of gathering the information. However, that's the only data we've got to work on, and so we must consider it. And when we look at the number of vaccines received by an infant, the mortality rate increases with that number of vaccines.
And again, we discussed in our previous joint interview with Ted. You've referred to the papers by Gary Goldman and authors in paper that document this at an inter-country level. So if you plot the number of vaccine antigens that a baby receives against the SIDS death rate, you see a pattern.
In terms of SIDS, however, all we know is between 43 and 51% of those reported deaths are SIDS.
Okay.
About half of those reported deaths are SIDS.
Yeah, so just to be clear, because
that's all we've got to work with.
Yeah, I can't remember if I said this, but the Goldman paper, if I do remember correctly, is about infant mortality rates, which is more than SIDS. But what you're saying is that SIDS is a major component of infant mortality.
Exactly. Yes. So we'd be foolish to ignore that data, although it's got certain problems and interpretation.
Potentially career-ending problems, yes, indeed. Yeah. Okay, so you use the term hyperimmunisation in your paper, and there's an intuitive obviousness to the term hyperimmunisation, but I always like to define things. So, so could I get you to define what do you mean, or is there an agreed upon meaning to the term hyperimmunisation?
Yeah, this was developed by vets to produce very high levels of antibodies, usually in horses or sheep. And it's these high levels of antibodies are created by repeated multiple injections of the specific target antigen. Mm-hmm. And through this you can achieve very high antibody levels. However, in some cases it can have very damaging effects on the immune system. It can lead to immune tolerance, where the immune system fails to recognize the target antigen, and it can lead to autoimmune disease and other very adverse immunopathological outcomes.
Okay. Two things that I want to clarify. So you said that hyperimmunisation, sorry, just correct me if I've misunderstood you. You said that hyperimmunisation can occur when you're injecting the same antigen multiple times. So say serial shots of, let's just take pertussis as an example. So serial shots of the pertussis vaccine. Did I also hear you say that hyperimmunisation could also mean that you're injecting multiple antigens at the same time and serially? Okay, so it's both. Second thing is the failure of the immune system to respond appropriately. Is this the IgG4 class switching that was highlighted with the mRNA COVID shots?
Yes, that can be involved, yes.
That's one of the mechanisms. So there are other mechanisms for immunosuppression besides the IgG4 class switch.
Yeah,
okay.
Sure.
Gotcha.
But when we look at the childhood immunization schedule, then we're getting many different antigens repeatedly injected. Mm-hmm. And that could represent a problem. And this needs to be examined and in proper controlled studies. And it hasn't been. That's the problem.
It has not been, and it's enormously difficult to do. I don't know if you saw it, but a suit has been brought in the US where essentially the government is being sued for having put 72 different vaccine antigens on the schedule without actually testing whether they're safe in combination or in the order given or in the combinations given or whatever. So it'll be interesting to follow. Okay. And let's see. So you touched on this serial injection of either the same antigen repeatedly or multiple antigens also repeatedly, potentially inducing autoimmune disease. And I'd love it if you could elaborate on that.
Well, the repeated injections can result in the immune system turning against itself in a way and reacting to its own tissues. Basically, and that can result in various clinical manifestations, arthritis, skin diseases, eczema, some
asthma potential,
and asthma. That's right. Yeah.
Okay, interesting. And Yeah, many of those we've seen skyrocketing incidences of. Okay. One of the risk factors for a higher twin rate, just going back to the twinning issue that you mentioned in the paper, was the increasing use of IVF, and in particular the transplantation of multiple fertilized embryos.
Yes.
Now, that practice, as I understand it, has been replaced by implantation of single embryos to reduce the twin and multiple pregnancies rate. But maternal age is a risk factor for twin pregnancies as well, as I understand.
So. Yeah. I'm not fully over that data, but
I did have a brief look at that, and it doesn't seem to be hugely dramatic. It's not like, twin rates double once women get past 25 or something. But there is a steady uptick in the twinning rate as women get older, and of course, women are having babies generally later and later in life now. So, okay. And what we do about that, nobody seems to know. That's a very, very thorny issue. Okay. Now there were so I'm just going to bring the paper back up, because there are a couple of other factors that I wanted to highlight. So one thing that I was really interested in, again, we touched on this briefly when you and I and Ted all spoke together, but this evidence that respiratory infection is very closely linked with SIDS, that respiratory infection is a primary risk factor for SIDS. The awareness of this goes back a long way, and yet you say this knowledge has been largely disregarded when it comes to research into causes and potential treatments for SIDS. What do you make of that?
I can't understand why it hasn't been explored. It's extraordinary. Only a handful of people have done this, and Caroline Blackwell, whom I mentioned in our last interview, certainly was very much into this and developed a very good theoretical and also laboratory-based data supporting an upper respiratory related cause. Usually, because what actually happens, and she showed that when one gets a upper respiratory viral infection, it actually can switch on colonization of the upper respiratory tract by toxigenic bacteria, including Staph aureus and E. coli. And even she showed that placing a baby prone actually increases the amount of bacteria in the nasopharynx. It causes pooling of secretions, and the tendency to an overgrowth of staph. And staph is a nasty organism because it can produce a whole range of different toxins, exotoxins, that can be absorbed into the system. And in the earlier times, those toxins have been demonstrated in SIDS tissues. In up to 50% of cases, they were found in kidney tissue in SIDS, and that work was done by Jim Morris and his colleagues.
So staph is a normal inhabitant of the microbiome of various body compartments. I mean, there's staph on the skin, there's staph carriage in the throat. So there's some factor that is making the staph go invasive.
Yeah, and that's the viral infection. Yeah. And of course, the viral infection disturbs the mucosal integrity and allows these toxins to easily slip across into the bloodstream.
Would it be true to say it's not just the viral infection, it's the immune response to viral infection? Because the immune response to viral infection is, heck, that cell is virally infected, I got to go destroy it. So now you've got a disrupted mucosal layer, and this is where the staph can go invasive.
Yeah.
Okay, interesting. Right. So there may have been some impact of the Back to Sleep campaign, but it's secondary, or that would be your
maybe a contributor. Yes. Yeah.
Maybe a contributor. But the principle is reducing respiratory infection and the risk factors for respiratory infection.
Yes.
Yeah.
And we noticed that after the campaign was introduced, respiratory viral infections did decline probably nearly by a half over those decades.
Any idea why?
Who knows? It's we don't understand the epidemiology of viral infection, why we get a big flu season one year and then a very low one in subsequent years. We don't know.
That is the pattern, isn't it? A severe flu season and then, a year or several years of a mild strain. Yeah, super interesting.
Some people could even attribute these events to sunspot activity. And
some people mightn't they?
I've actually looked at that in relation to SIDS, but there is some correlation to sunspot numbers and SIDS numbers. It's very fascinating.
That is unbelievably fascinating. So sunspot activity, that there's also a relationship between that and the strength of the Earth's magnetic field. Is there?
That's right.
Yeah.
And also weather that is largely dictated to by these changes in
space weather,
magnetism and sunspots. Yeah.
So just how many public health researchers are taking sunspot activity into account when designing SIDS studies?
Not too many.
Not too many. That would be considered pretty wild. Yeah, good luck getting a grant for that. Now, let me see. So we've discussed the increased twinning rate and the risk factors for that. And let me see. So we've talked about this immunotoxicity and the immunosuppression and immune tolerance. Yeah. Now, again, this is something that we discussed along with Ted. So this passage here, it's been argued that the current childhood immunisation schedule is fundamentally flawed because it aims to provide circulating antibodies for pathogens that do not usually enter the bloodstream. So in other words, you're sticking a needle in the arm to generate antibodies that will circulate in the blood, but the infection enters via the respiratory tract and the virus sort of stays put within the respiratory tract, or maybe it gets into the gut, but it doesn't get into the bloodstream. Yeah. So
there are pathogens such as measles, mumps, and rubella that will cross into the bloodstream.
Yes, so and Haemophilus influenza.
Producing circulating antibodies for those is not unreasonable, but the best protection one could give is to provide IgA at the mucosal membrane by just using a topical mucosal vaccine. And this is what I'm pushing for the future of immunization.
Yeah, this is what, and again, we talked about this previously, this is what you want to see the research directed into. And so, okay, I know we have limited time today and I don't want to keep you longer than our agreed upon time. Now, let me phrase this very carefully. Your suggestion then, or what would you advise parents considering the current vaccine schedule, what would you advise them to bear in mind if there were no economic pressures on them, if they weren't if they weren't being influenced by the government withholding payments for this, that, or the other? Which of the current vaccines do you think are well targeted? And what would you say about the current spacing of the vaccines that are administered via the schedule?
It's such a difficult one to answer. However, one must consider the maturity of the infant. One would be very careful about immunizing very prim babies, particularly when they have a respiratory infection. Avoid, in my opinion, would avoid vaccination if they have an apparent respiratory infection and are off color.
As I understand, it used to be a contraindication to vaccination, but it's not really honoured
now. Well, fever definitely is a contraindication.
Yeah,
and that should be abided. But it's very difficult to give advice on this one. But
sure.
I think parents need to consider very carefully that situation.
Yeah, so think it through, look at each vaccine, the disease to which it's associated, the individual risks of the child. The difficulty is, of course, that you've also got the doctor at the other end of this equation, and the doctor is under enormous pressure to stick to the schedule.
Right. And you've got the higher risk of the daycare centre. That is, a great place to pick up these infections. And it's only logical to attempt to prevent those infections through immunisation, particularly as they're going into that situation. It would be far better if the economy could reorganise itself to allow women to breastfeed at home for at least 6 months to protect the infant from exposure and also to boost its immunity through breastfeeding.
Yes, to provide those antibodies that do actually last quite a long time.
Yeah, those critical months, that's right. Yes.
And of course, whatever, if the mother is spending most of her time with the baby, whatever the baby is exposed to, she's exposed to, which means her immune system gets to work, and then provides that. Although there's a delay, of course, between exposure and the production of antibodies, but nonetheless, there's some protection there. And I suppose this brings us finally to the issue of just what happens to parents who begin to question the vaccine schedule. And sometimes it's because they have had a very negative experience with so they've taken their previous child, their firstborn, say, along to get their vaccines, and then, something untoward has happened. In the most severe case, the child has died. In other cases, there's been some neurological damage done to the child that they attribute to vaccination, or the child has developed asthma or eczema or something else, which the parents, rightly or wrongly, but on the basis of their experience, attribute to vaccination. And so there was a really interesting editorial penned in the BMJ by Peter Doshi, who's a really smart guy, who was really just on the right side of everything when it came to the development of the COVID vaccines. And I was quite impressed that the BMJ continued to publish his articles, even though he wasn't saying the popular thing. But I I'm just going to bring this editorial up. Oops, no, not that one. Let's take that one down. I want that one there. Yeah, there we go. So this was actually, although it refers to Trump, this was Trump 1.0. This was the first Trump. So this was published back in 2017, and there's a couple of sections that I won't read out all of this, but I just wanted your comments on some of the statements it makes. Okay, and man, I'm having to get in close to read this. So what he writes is that if patients have concerns, doubts or suspicions, for example, about the safety of vaccines, this does not mean that they are anti-vaccine. Anti-vaccine positions certainly exist in the world, but approaches that label anybody and everybody who raises questions about the right-headedness of current vaccine policies, myself included, meaning Doshi himself, because he was attacked as an anti-vaxxer, which is quite hilarious, as anti-vaccine, fail on several accounts. First, they fail to accurately characterise the nature of the concern. Many parents of children with developmental disorders who question the role of vaccines had their children vaccinated, which, again, I mean, this is quite the important point. You know, if a parent is saying, hey, I took my kid along to get his vaccines and now he has autism, accusing them of being an anti-vaxxer is a little bit off base. Like, they actually took their kid to get vaccinated, so they certainly weren't an anti-vaxxer at the time. In other words, it's not an ideological position. It's a position that is arrived at based on that family's experience. The second point that he makes is so important. Secondly, they lump all vaccines together as if the decision about risks and benefits is the same, irrespective of disease. Polio, pertussis, smallpox, mumps, diphtheria, hepatitis B, influenza, varicella, HPV, Japanese encephalitis, or vaccine type, live attenuated, inactivated whole cell, split virus, whole dose, high dose, low dose. God, who knew there were that many vaccines? I won't go on reading all of that. This seems about as intelligent as categorizing people into pro-drug and anti-drug camps, depending on whether they've ever voiced concern over the potential side effects of any drug. Amen to that. You know, it's what would we have thought if the people who first started raising concerns about thalidomide were dismissed as being anti-drug cranks, as opposed to people who had observed, hey, this drug seems to be causing, you know, horrendous birth defects in children. We ought to look into this drug. So, yes. Anyway,
yeah. No, I agree. His sentiments are spot on.
Yeah. Have you ever been accused of being an anti-vaxxer, Paul, because you raised these concerns?
Not sure. I'm not aware of it. There may be people out there, but...
None of your colleagues have said this to you. Fair enough. Yes. I've always thought it was a rather stupid term myself. I mean, again, they're... I guess your argument would be that there are certain vaccines that would be wise to administer to certain people in certain circumstances.
Yeah.
But that a blanket policy of all these vaccines at this schedule for all babies, regardless of whether they're singleton births, twins, higher multiples, born full term, born premature, born whatever the hell, regardless of what their state of health is, regardless of whether they were born by C-section, breastfed, bottle fed, whatever the heck, that's the policy that, you know, this sort of universalist policy is what you would say is not particularly sensible.
It should be based on risk, but of course trying to organise vaccination of children, the simplest approach is that broad, all-sweeping, all-in-one bucket approach. And I think it needs to be modified and improved.
This to me goes to the heart of public health versus medical practice. In medical practice, the patient sitting across from you, or the baby in the mother's arms across from you, is the patient, and you as the doctor are making individual decisions based on the well-being of the patient. In public health, it's population wide, and right. As a doctor, you don't treat populations, you treat people.
No.
Yeah, there's a real problem there. Actually, I did my honours degree in public health, and it's a very interesting field of study. And the early public health movement, which really cleaned up those disgusting industrial slums, did so much good, enormous good. And then I think things went a bit haywire after they'd kind of sorted out the plumbing issue, delivering fresh water to people, removing the waste, and preventing the overcrowding in the slums, and getting some safe work regulations in, like all that. 2 thumbs up, right? That was fabulous stuff. Yeah. Anyway, all right, Paul. It's been wonderful to speak to you once again. Thanks so much for sending me this paper. Was there anything that we didn't cover today that you would like to get out there?
I think we've covered it. I guess I could point out the studies from Africa, which showed that the diphtheria, pertussis, tetanus shots were a bit of a problem, and there was an increased mortality rate in infants who had received more doses of these vaccines. And I've used that study there to illustrate it from Arby.
Yes, I'm just trying to find that section of your paper, which I didn't highlight. But yes, so there was the interesting. Sorry, let me do a search here. The Arby paper. That was reference 104. So yeah, this was the fact that. Sorry, I'm still trying to find this in the actual paper. Okay. No, I won't waste time trying to find the actual page that's on. But essentially, these studies that Peter Arby and colleagues did in African countries found that the ratio of female to male deaths, interestingly, varied depending on what was the last vaccine administered. And
that's right.
It was the DPT vaccine, which is different to what we use here. So they use the whole cell pertussis in African vaccination campaigns because it's cheaper. And we use the acellular pertussis vaccine here. So just for my audience's sake, pertussis meaning whooping cough. And so Peter Arby's group found that there was this really striking increase in the death rate of female infants after that DPT vaccine. There seems to be something about that DPT vaccine that's particularly toxic to little baby girls.
And I point out that females actually have a greater susceptibility and poorer outcome from pertussis than males. So it's one of those quirks of nature we don't understand, but that's probably, obviously, somehow genetically linked. But
yes, that is particularly interesting because, of course, the neonatal death rate or the infant mortality rate generally is higher in male infants, isn't it? So we have slightly more male babies conceived, but then by the time you reach the first birthday, it's evened out because more baby boys are in the first year. So this is really interesting.
Yeah. But it's skewed by this vaccine. The male-female ratio is reversed. And possibly we should be considering the adjuvant associated with these vaccines. And as far as I'm aware, alum is the adjuvant used in these vaccines and also in the acellular vaccine. So, like Ted, we both have concerns about alum because it tends to switch on the Th2 branch of the adaptive immune response. And that can lead to problems because those antibodies, the IgG antibodies, specific ones, can react with complement, which is a serum protein, and produce immune complexes, which can cause immune complex disease, which can be highly inflammatory and potentially deadly.
So the Th2 immune response is pro-inflammatory, and then we also see this linkage between aluminium adjuvanted vaccines and autoimmune conditions.
Yeah, we do.
Yeah, and then we see generally the rate of autoimmunity is higher in females than males. There are a couple of specific autoimmune conditions that are more common in males, but the overwhelming majority of autoimmune conditions are more prevalent in females than males. So that's a very interesting set of linkages, isn't it? And I mean, and it needs further study, and that study has to get funded.
Sure.
And when vaccines are this holy cow, anyone who says, I think there might be a problem with aluminium adjuvants, could I have some funding, please, sir? May I have some funding to study this? No, actually. And in fact, that promotion you were hoping for, sorry, bud. Yeah. So,
well, maybe RFK Jr. might come up with some money. You never know.
Goodness me. I mean, look, he's up against it. He's so up against it. He's really got the massive forces of the pharmaceutical industrial complex and all sorts of other interlocking complexes, I suspect, just lined up against him. Yeah, wouldn't be him for quids. So, all right. So thanks, Paul.
Yeah, he seems to have resolved the terrible conflicts of interest in the Immunization Advisory Committee.
Yeah, the AC committee.
Which I couldn't understand how that could happen. I mean,
that was astonishing. Anyone who took to watching ACIP meetings as they were streamed live during the whole COVID debacle was just sitting there scratching their head, going, like, this looks like a meeting of mob bosses, like conflict of interest on a massive scale. I mean, not to name names, but why not? Paul Offit. I mean, how does a guy with multiple vaccine patents get to sit on ACIP? It's just, it's wild. And then their excuse was, well, we can't form a commission that doesn't have conflicts of interest because they're all working for the drug industry. And I'm thinking, there's your problem right there. I think that's your problem. Yeah, but as we touched on the last time we spoke, along with Ted, the issue that we have is finding a funding model that actually works, finding a funding model for research that enables scientists to do good, honest work and actually get it published and not be gatekept by the journals and so forth. And there are so many impediments to getting that funding stream operative. And I don't know if you're familiar with Kevin McKernan.
No.
He is the one who found the DNA contamination in the mRNA vaccines. It was his lab that actually found them. And he has proposed various alternative funding mechanisms, including essentially like a crowdfunding methodology that works via a blockchain, so that every step of the research process is actually completely transparent. And he's got some very novel ideas for reforming peer review. Peer review. I mean, again, great idea in principle, in practice. really problematic.
Yeah.
Just ask anyone who's got any doubts about, the consensus position on climate change. Good luck getting any of your naughty alternative perspectives on climate change published, because you can't get it past peer review. Yeah. That's all locked up really tight. So anyway, okay, I've kept you longer than you promised, and my apologies for that, but I really enjoy our conversation. And all I can say is please keep on working and publishing papers, Paul, so that I have an excuse to get you back on again for a chat.
Thank you. Enjoy it.
And I know I asked you at the end of our last conversation, where can people follow you, and it's not like you have social media or anything, but all your papers are up on your University of Adelaide website, which again, I'll put a link to that in the show notes so that people can read your previous work and, just look at what you're going to be up to next. Oh, yeah, sorry, just final question before we wrap up. Do you have another paper in the works? What are your research interests currently?
I'm still cogitating, but nothing specific at the moment. But of course, it is all centred around SIDS. Yeah.
Yes. All right. Okay. Keep me posted. And once again, I really enjoy our conversations. Thanks for keeping on working. Probably long past the point where your wife and family, you ought to be retired and playing golf or something silly like that. Okay. All the best, Paul.
Thank you, Robin. All the best.